for attending the inaugural kickoff of our Cancer Echo series. If you're new to participating in an Echo session, we start each of our sessions with the same basic structure. So we start off giving some brief introductions. We then move into a presentation by our guest speakers, which is then followed by an interactive case-based discussion. And then we'll have a brief session wrap up. So what I would like to do, since this is our very first Echo, I would like us to go ahead and start with introductions. Normally, we would ask you just to do that in the chat. But since this is our very first time meeting, we'd like to do a brief introduction. So we'll just ask you to tell us your name, your profession, and what clinic or organization you are from. I will get started. I am Mary Ellen Kahn. I am with Cancer Prevention and Control at the WVU Cancer Institute, and I will be facilitating today's meeting. Next, I'm going to ask our support team and our presenters if they could introduce themselves. So let's start with Andy.
Hi, everyone. I'm Andy Hazley. I am the program manager for Mountains of Hope, our state cancer coalition, and I'm assisting Mary Ellen in hosting the Echo. Thanks so much for coming.
And Jenny.
Hi, I'm Jenny Austin. I work at the WVU Cancer Institute. If you have any questions about Zoom or need technical assistance, please just let me know.
And Dr. Davison.
Hi, I'm Dr. Laura Davison. I am internal medicine and obesity medicine certified physician, and I'm the director of the medical weight management program, and I'll be presenting today and thrilled to be here.
And Dr. Haggerty.
Hi, I'm Tria Haggerty. I'm family medicine and also certified in obesity medicine and work in the medical weight management clinic at WVU. Also presenting today and excited to be here.
Okay, thank you. So now I will call on each of you, so as I see you on my screen, so if you could introduce yourself, let us know your name, your profession, and where you are from. So let's start with Kara.
Hi, my name is Kara Holdren. I'm a family nurse practitioner in Nicholas County, West Virginia. I work for Camden Family Health.
Thank you. Welcome. Crystal.
Hi, I'm Crystal Street. I'm the Oncology Quality Coordinator here at Mary Bab Randolph Cancer Center. I oversee the Commission on Cancer accreditation and the NAPBC, the breast program accreditation.
Okay, thank you. I'm real briefly, we got a chat. Marianne Yanosic, she's a registered dietitian, and Leanna Schwartzlow, they are with the WVU Cancer Institute, the Mary Bab Randolph Cancer Center. They're joining us, but they don't have a microphone today. So welcome, Marianne and Leanna. Dr. Ward.
Hi, I'm Christy Ward. I'm a gynecologic oncologist at the Cancer Center.
Okay. And Misa?
Hello, I'm Misa Shaw. I'm a clinical and translational science PhD student here at WVU.
Okay, welcome. Elizabeth?
Hi, everyone. I'm Elizabeth Minnick with West Virginia CTSI Project Echo, and I'm the project coordinator and work with Mitra and Jay.
Thank you. Laura?
Hello, Laura Nolf. I'm a family practice physician at Pendleton Community Care in Franklin, West Virginia.
Thank you. Welcome. Catherine.
Hi, I'm Kathy Shaw. I'm a registered dietitian and certified specialist in obesity and weight management. I work with Tria and Laura in the medical weight management program.
Okay, welcome. Mitra?
Hey everyone, I'm Mitra Salmasi and I work with Elizabeth and Jay. I'm the Project Echo manager for the West Virginia CTSI Project Echo program. Thank you.
Okay. And Yvonne.
Hi, I'm Yvonne Shaw. I'm the quality control supervisor at the Cancer Institute Clinical Research Unit up in Morgantown.
Okay, wonderful. And I believe I got everyone. If I accidentally missed someone, just speak up and introduce yourself. Okay, thank you. Before we get started, I just wanted to give you some other reminders and some housekeeping. If you feel comfortable doing so, we do encourage you to turn on your camera. It helps to make the sessions a little bit more engaging. We ask that you keep your microphones muted during the session. We do want to hear from you, so at the point where we get to the question and answers and also the discussion section, you can take yourself off mute, or you can raise your hand in Zoom if you'd like to speak. The session is recorded, archived, and excerpts of it may be used for educational purposes. And by participating today, you indicate your consent to us recording this session. We do ask, please remember not to disclose any personal information that could identify the patient cases that are presented during the session. And finally, this series is approved through the Accreditation Council for Continuing Medical Education to provide CME credits for physicians. And the Office of CME at WVU has designated this activity for a maximum of 1 AMA PRA Category 1 credit. This session has also been approved by the West Virginia University School of Nursing for 1.2 contact hours. So if you did not pre-register with us, please let us know in the chat if you would like CME or nursing credits. And so without further delay, I am going to let us get our session started. I'm going to turn the floor over to Drs. Davison and Haggerty. And also I will be pulling up the slides from my end. So when you would like the slides to be advanced, just please let me know. Let me get us in slide presentation. Can everyone see that? Okay.
Yes.
So I'll turn it over to Drs. Davison and Haggerty.
Thank you, Mary Ellen. So today our topic, the didactic portion of it, is about obesity treatment as cancer prevention. Dr. Davison and I are going to go over kind of a quick overview about what we know about this and what we can maybe do. You can go to the next slide. So some reasons why it's important, the background. Overweight and obesity rates are above 70% in the United States. With that, we know that there are some health issues that come with metabolic conditions, which obesity is related to metabolic conditions. Metabolic conditions account for 6% of all incident cancers worldwide. So it's got a really important, it's important for us to know more about this and how metabolic conditions affect cancer. Some of the known cancer risks that we know are included: genetic predisposition, ionized radiation, tobacco use, infections, dietary factors, alcohol consumption, sedentary lifestyle, environmental exposures, and diagnosis of obesity. If you look at this list, quite a few things that we know as known cancer risks, we would be addressing when we're addressing weight management in the clinical setting. So I highlighted some of those in blue. You could make arguments on the other ones too. But I did highlight the ones in blue that we commonly talk about in our clinical setting. You could get the next slide. There are a host of obesity-related cancer types, and I've listed those here. So esophagus, colorectal, gallbladder, pancreas, liver, breast, ovarian, endometrial, kidney, and prostate. There's some research out there that shows why for the different cancer types and what would be associated with that, but we don't have real in-depth understanding of this yet. So the research is still going on. Now, the etiology, where I say that we have some understanding. So metabolic syndrome is associated with a few things that might be associated with cancer risk. So hyperinsulinemia, visceral adiposity, increased circulating estrogen, inflammatory cytokines, and altered circulating adipokines. Now, with the implicated in cancer risk, we know that elevated insulin and also elevated insulin-like growth factors are associated, also hyperglycemia and elevated triglycerides or low HDL. And some of the things you can think about is with elevated insulin-like growth factor and insulin we do see proliferation of cells, and that includes of tumor cells. Now, one of the things that we have to think about in the medical arena is that obesity is a chronic condition. So one thing that we have missed quite often is that, it's not a personal failing, that there are hormone backings that go with obesity, and those have to be taken into account when we're thinking about treatment of obesity. So the Obesity Medicine Association gives a great definition, saying it's chronic, relapsing, multifactorial neurobehavioral disease, wherein an increase in body fat promotes adipose tissue dysfunction and abnormal fat mass physical forces, resulting in adverse metabolic, biomechanical, and psychosocial health consequences. So when you think about all of those going together, you can see where obesity would have some risk related to cancer.
So Dr. Haggerty did a great job explaining the association of obesity with cancer. So the next question is, can treating obesity actually reduce cancer risk? And that's a really challenging question. And there's a couple reasons why that's really hard to answer. And one is because there's this long time period between, it takes a long time for cancer to develop. So if you were changing something like weight loss, and then you want to see if cancer is decreased, you have to follow it for many, many years. So it takes a certain type of study to be able to do that. And that makes it really challenging. The other reason why these studies are challenging is because it's so rare for patients to actually achieve substantial and sustained weight loss. And so if there aren't many patients actually achieving that, you don't have a lot of patients to study. So when you look at historically who has successfully lost weight and kept it off, our best patient population is really the bariatric surgery patients. So most of the studies that we have is based on the bariatric surgery patients. So next slide. So the most recent study was just published this year. It was Cleveland Clinic study, and they found that patients who achieved weight loss through bariatric surgery had 32% lower risk of developing cancer and a 48% lower risk of dying from cancer. So that did confirm that treating obesity reduces cancer risk. Next slide. And you can see this is from the same study. The top graph shows the weight loss differences between the control group, which did not have surgery, and then the bariatric surgery group. And clearly, as expected, the bariatric surgery group lost a lot more weight than the non-surgical control group. And then on the lower slide, you can see they broke it down into quartiles of weight loss of the patients who had surgery and lost weight. And those in the quartile 4 who had the most weight loss did have the lower cancer risk. So it seems like there is this association with more weight loss with more cancer reduction. So even though we don't have studies in non-surgical patients at this point, we would think that it would be similar. And now that we're getting better treatments for non-surgical treatments of obesity, we may be able to start seeing some studies that will confirm that in the future. So any questions before we move on to the next part of the echo?
I have a question. Whenever you mention bariatric surgery, does the type of bariatric surgery play a part?
Well, that's actually really interesting. So there were some older studies that also showed a difference in cancer rates with surgery, and those were with older types of surgeries that aren't really used as much anymore. So this most recent study was the most common types of surgery, the sleeve gastrectomy and the Roux-en-Y gastric bypass, and it actually showed similar results from both groups, which is important because that suggests that it's the weight loss, not necessarily some other part of having the surgery that is associated with the cancer reduction.
I have a question. Do you so patients that are on hormone suppression medicine for like post breast cancer treatment, that show weight gain. Have you had successful strategies for those patients in managing that short-term and long-term?
Yeah, obviously that's definitely a factor that can make it harder for people if they're on medications that are weight promoting. And, we would use all of our strategies that we would typically use for weight management and try to work around that as best as we can. Some people are on medications that are weight promoting that aren't essential. And in those cases, we definitely take them off of those medications if they don't need them and they're promoting weight gain. But obviously, if it's a medicine that's required for their cancer treatment, we would just have to work around that.
Yeah, Andy, so we would still approach those patients with the 4-pillar approach, which is nutrition, movement, behavioral change, and medical. On that medical side too, we would be able to use some of our anti-obesity medicines with taking into account what medicines they're on. So hitting that pillar would be still an option in those patients.
Other questions?
Okay, so we're going to move on to Mary Ellen is having computer difficulties. It's okay. We're going to move on to our case presentation. And Jenny, did Mary Ellen send you that slide as well? No? Okay, I have it. So if you'll give me just a minute, Dr. Ward, I'll pull up that slide and then you can do your case presentation and we'll follow from there. Can everybody see that okay? We good? Okay. All right, Dr. Ward, I have it up split like that. If you need me to move back, forth, whatever, just guide me along and I can help. The floor is yours.
Okay. So I was sent a 39-year-old lady who had been being followed by gynecology because she was trying to get pregnant. During her workup for her infertility, she was found to, she had endometrial biopsy and was found to have complex endometrial hyperplasia with a tibia. She'd been trying to get pregnant for about the past 2 years and was diagnosed with PCOS. She wasn't started any hormonal therapy since she was trying to get pregnant. She had gained a significant amount of weight from 275 to 354 over the 2 years that she was following with her OB. She actually had several biopsies given her obesity and abnormal bleeding, and all of them were negative except for this last one. Other than obesity, her only other comorbidities is polycystic ovarian syndrome. Can you scroll down a little bit? Relevant physical exam and lab results. She had not had a recent hemoglobin A1C. Her past one done by her PCP had been within the normal range. Exam just revealed a pleasant obese female with a normal size uterus on imaging and exam. Medication, she'd been placed on metformin due to the PCOS. And then questions about the case, and then what would be an appropriate way to address weight management to help this patient prevent cancer, as complex endometrial hyperplasia with a tibia is a precursor lesion for endometrial cancer.
So thank you for the case. I think the most important thing to note from this case is just recognizing how important it is for this patient to lose weight for cancer prevention, because she is at such high risk. And we know that endometrial cancer is one of the cancers that has the strongest association with obesity. So, you know, and I don't know if you know this patient's BMI offhand, but, you know, generally when we're seeing a patient, we're going to look at the BMI to guide treatment options. And typically if someone's BMI hits 25, 27, we would think about lifestyle changes. Then if they are between a BMI of 27 to 30, depending on comorbid conditions, that's when we would think about medical treatments for the obesity. And then 35 to 40 BMI is where you would start to think about surgical treatments for obesity. But in general, if she came to us for medical weight management, we would use the 4 pillars of our treatment strategy, like Dr. Haggerty mentioned earlier, which is the food, the nutrition, the behavior change approaches, and then the medical therapy. And I think in this particular patient, what makes it really interesting is the timing of her wanting to conceive.
Mm-hmm.
So, you know, even if her BMI was in the range where surgery would be an appropriate treatment, it's very clear that patients who have bariatric surgery are not supposed to get pregnant in at least 12 to 18 months after surgery, because they don't want to have large shifts in nutrients, large weight loss during pregnancy. So given that she's 39, it sounds like she's actively trying to conceive, surgery would probably not be a good option for her. Similarly, some of our treatments are contraindicated if someone is either pregnant or trying to get pregnant. You're not supposed to be doing any active weight loss while someone is pregnant. But while they're trying to get pregnant, there are certain medications that we would have to avoid during that time period.
Some things that I would think about with her too. One thing that a lot of people go for first is they think about nutrition and movement, which are both, of course, 2 pillars of the 4 and incredibly important. And they can be important too, especially I think the movement side in the future of health with pregnancy and delivery and all that. But in this patient, I would want a much more detailed history for weight management. And one reason I would think about that, she has had significant weight gain in a short period of time. And I definitely want to look into if there could be any chance of things like disordered eating, or specifically with her, maybe binge eating disorder. And that would go into some thought process about that medicine. There's certain medicines we might think about using in somebody with binge eating disorder, if she had it, that would be contraindicated for pregnancy. And specifically one I think about is Topamax that we would use in that setting. But it's contraindicated in pregnancy due to increased risk of cleft lip and palate. So that's one thing. The other thing, whenever I was looking up some information about nutrition and cancer risk, even that JAMA article that came out recently, they kind of said, you know, we don't know what the best nutrition plan is for patients, but we like the Mediterranean. There is data that the Mediterranean healthy nutrition plan might decrease cancer risk. And I think some people can see that and then be like, oh, everybody needs Mediterranean diet and therefore they'll have decreased cancer risk and things are better. But we don't really know diet wise. What we do know is that having a healthy eating plan would probably be the best thing for her. But there's different eating plans that might be better for her based on her history. There's different reasons lifestyle wise why we might pick an eating plan. So there's not a single one eating plan. I was kind of interested in how that JAMA article listed that, because I think you could easily walk away from that article saying that Mediterranean diet was the way to go, and maybe it is. I don't know. We don't have the data on that, but I do know that we could go multiple directions with her diet, and I think that's important to understand when we're taking care of the patients. There's not one single diet that works for every single patient.
So as Dr. Haggerty mentioned, you know, there's a lot of history that would be useful in a case like this. And, you know, when patients come to our clinic, they fill out a very lengthy intake form before they come to see us. And so, you know, that does try to address a lot of the other issues that could be going on and discovering things that way. So it's certainly a forum that, you know, if anyone wanted to try to start addressing weight at a weight specific visit in their clinic, you would be welcome to use our forum if you wanted to use that to try to get more detailed information about some of these issues that could be going on that might otherwise get missed.
I guess maybe because this case could go multiple directions, maybe we can open it up to questions related to obesity management or this case to help identify what direction the group would like to talk about.
I have one quick question. So at what point these patients visit the clinic? Is there any, like, because of the risk like they're facing, or because they're willing to see someone for help, or do you see any variation? Like, what would you see? Is there any patterns?
I don't know if you want to take that, Dr. Davison. Go ahead.
Sorry, I saw you were unmiked, so I thought you were taking it.
No, I just left it unmiked.
Okay. So we're happy to take patients at any point. You know, I think, you know, patients can get to our clinic a lot of different ways. You can be referred by a clinician who is concerned about the patient. But patients can also self-refer. So they are more than welcome to, you know, Google us, look at our website, even start the intake form right there to get that part of that done. What we would recommend is probably sooner rather than later. We don't have, I mean, obviously we have a lot of patients who want to come see us and we can be busy. So, you know, we generally say at a BMI of around at least 25 to 27 would be a good time. Would be at least kind of the BMI you should have to see us. Probably we have taken some patients who are less than that. But in general, if you are 25 BMI and above, you know, I think coming to see us earlier is probably better, because what happens is as the severity of the obesity it increases, it gets harder to treat. You know, and I think, you know, if anyone has ever gained weight before, it's, you know, it might not be that hard to put it on, but then to take it off is really, really hard. And you can end up pretty discouraged and it can get really hard. And in fact, some people have gained so much weight that they're not even candidates for, you know, our most effective treatment, which is the surgical weight loss. So we definitely would really like to see people before they get to the point where they have exceeded even the capability of having surgery if they were to need it. So yeah, I think sometimes people tend to see us maybe a little too late, especially in West Virginia. The average BMIs in our clinic the average BMI is 43, over 43. So we're seeing people who have pretty high BMIs, and we'd love to see them a little bit lower where we can kind of prevent it from getting too hard to treat.
I think the important thing with that is the difficulty in losing. There's been a lot of emphasis in the past placed on nutrition and movement, which of course is important, but not as much into how the hormones do change when somebody has that weight gain. So we're able to add that medical approach to and give them quite a bit more support in the nutrition, movement, behavioral change side, but adding that medical kind of helps with the hormone changes that happen with weight added on.
Yeah, what's pretty much recommended, especially in the primary care setting, would be to give the initial counseling and give some initial guidance. But if patients aren't really responding to either, you know, really ramp up the intensity of the treatment provided in the primary care setting, or if that's not possible, because we know how busy people are, to refer to a specialized center like ours, where we have the setup basically to try to provide the really intense support that's needed to help with the weight loss.
Thank you.
As a woman with PCOS, it is very, very difficult to lose weight. I could eat 1,000 calories a day, and I mean, I'm not like hardcore running or anything, but I could walk daily, barely eat what I want to eat, and still not see weight shift. So I do think that, you know, if you do have this condition, you do need extra help. I'm going to a clinic where I live now. Nothing's really worked until recently, and I'm like on a peptide drop thing I take 3 times a day. It's like a more of a holistic approach, if you will. And because I couldn't afford the medication, so I was just curious. Also, you know, I do think lower carb has helped me. If others have my condition, I try to avoid gluten when I can. Right now, I haven't had it in months, and dairy products. But I didn't know about the clinic there. If, you know, do they cover, you know, I am in the BMI that would be considered, you said above 27 would be for medication. But when they try to put me on medication through my endocrinologist, it was just too expensive. So I was just wondering, when do they start to help people without it having to come out of my pocket with my BMI, unless I'm diabetic 100%, because I am insulin resistant.
Yeah, we run into the medication cost issue quite a bit, but we work through it quite in a lot of different ways. One, there's a host of about 6 approved weight management medications that we use regularly. And those, well, 5, I would say we use regularly. There's one we don't use too awfully much, but those medicines have a varying degree of cost associated with them, and why they might be approved, meaning, you know, as I'm sure you might be talking about, is the GLP-1s have a pretty significant cost, and they are ones I would think about in patients that have some reason for insulin resistance. But of course, I think about them with patients that don't have insulin resistance too. So there's different ways to work through the cost associated with those, but sometimes they're just not an option without out-of-pocket expense. Yeah. Dr. Davison's done a good job at working with the hospital insurance and people like that to get them covered. We are working now with PIA, so they'll cover them from our clinic with that. But then outside of that, it just depends on what the patient's background medical history is. So whenever that cost is a problem, then I start looking at my other options. So we do use medications, the other medications in the class. And there might be times that I'm using those before I use a GLP-1. I think everybody gives the GLP-1 like this gold standard pedestal that should be on. I, of course, love the GLP-1s, but there might be a reason. You know, I have a patient that would come in and say, I just really like food. I sit down and I think about chocolate. I sit down and I think about what cereal I can eat, and I'm not even hungry. I just start thinking about this. Then I might want to go more of an addiction approach route to the food, you know, that help them from that side. And we're looking at cheaper medicine in that way, even if not covered. And there are other ways that we go about getting it to be cheaper. So that, and then like I mentioned, things like binge eating disorder, I might think about something along the lines of Topamax, which is off-label, but think about going that direction for binge eating disorder, and not necessarily always a GLP-1 that has the cost associated with it. We're truthfully right now, it has a supply chain issue associated with it. And our patients are just left and right having to figure out how to work with us and with their obesity without GLP-1s, because we can't get them on the shelf. So
the other thing is to think about combination therapy. We're doing more of that, and I think that'll be more of an up and coming thing where you can kind of treat the obesity from 2 different approaches and get even better results. A couple words about getting coverage. Although there are certain times when we can write appeal letters and get things covered, we also sometimes can run up against a wall. So sometimes people will come to our clinic with maybe unreasonable expectations, thinking that we have some magic that we'll be able to get something covered. But there are a lot of insurances where these medicines are just flat out not part of the benefit package. And it doesn't matter what you say, what letter you write, it's just not a covered benefit. If they don't have another medical indication for the medicine besides obesity, unfortunately. So that is an issue. We're doing a lot of advocacy to try to address that locally and even nationally. But that is a big problem. But sometimes, depending on the insurance, we do have some ways we can get around it. But I also don't want people to come to see us with the expectation that we can always solve that problem, because we cannot necessarily always solve it. It just really depends on a lot of factors, the medical condition and the insurance coverage.
Then the other thing to think about with the medicine, when you say like insulin resistance, if you come to our clinic and a lot of clinics, you would probably find out that we want to approach the nutrition, the movement, the behavioral change side. I always tell patients that I think of those pillars as being equally important to the medical, because I think sometimes people come to us with that medical pillar being kind of on a pedestal. And so linking those together. Now I will say, there are times where the medical pillar is adjusting the nutrition pillar, or the behavioral change pillar is adjusting the movement pillar. One thing that we work with the patients is changing those. When and Dr. Nolf, I know she works in primary care. I don't know if Holdren, if you do, but in primary care, I spent 10 years in primary care with my hand on the door, not because I wanted it this way. It was because I had 12 other patients on my schedule at that moment saying, well, eat better and exercise more. And getting into how to address that more specifically wasn't something we were necessarily taught in med school. It wasn't something I necessarily understood, but even more, it wasn't something I necessarily had time to go through with patients, which is completely wrong, but it was how it was. And so having approaches to how to deal with that has been important for me. And we can do that from our clinic, but.
Thank you. It's just very important. And I agree, if there's a correlation between cancer, which you do see in this case of PCOS, I've been told, if I skip so many months, I need to basically like jumpstart myself with the pill so that I have that, don't put myself in a higher risk for cancer. So I'm hoping like down the line that because there is a correlation or we're seeing maybe perhaps there is, that things will get covered a little bit better for those that can't, come and afford such practices.
There's one more thing I wanted to say about the medical pillar, and that is that it's not just prescribing anti-obesity medications. Our medical evaluation, actually, it looks for other underlying causes of weight gain. We look for possible sleep problems that could actually make it harder to lose weight and address that specifically. Sometimes getting people into sleep cognitive behavior therapy. We look for the disordered eating patterns. So there are other medical things too, besides just, giving an anti-obesity medication that fall into that pillar.
There's a lot, like the weight promoting effects of insulin is important, but I get patients all the time that their primary care provider did check their A1C and it was pretty okay. And then a year later, it's in the range of diabetes, a diagnosis of diabetes. And so they're saying they're wondering why they're gaining weight. And I'm like, well, your body was working on it for the last year as your insulin kept increasing and increasing. I feel like it's very much a circular effect. And so their primary care physician had checked the thing, but it behind the scenes that insulin was going up.
One more point about coverage issues. Sometimes I'm not sure everyone always understands how the insurances work, but basically if you have employer-based insurance, you'll have an insurance company, let's say it's Blue Cross Blue Shield, then they will contract out with a pharmacy benefits manager who decides on the formulary that will be covered for patients on that plan. And then when you look at what comes in the standard benefit package for a pharmacy benefit manager's formulary, obesity treatment is not part of the standard benefit package. So an employer actually has to opt in and take this additional step to get those medications covered. And so a lot of times the employers don't even know that they have to do that additional step. So that is an opportunity for even, employees to advocate with their HR departments to start bringing that up and directly asking for them to opt into that particular coverage. And that can be really useful. And there's an obesity action coalition that has a lot of advocacy tools that patients themselves can start using to try to turn this around. We're doing our part, but if everyone does it and they keep hearing it from all different places, I think it might be more effective. So keep that in mind.
And Dr. Davison, is that coalition, are they national? Are they specific to the state?
Yeah, there's a national coalition. They've got a great website with lots of resources. So Obesity Action Coalition, definitely check it out.
Okay. Any other questions? Feel free to ask, or you can put them in the chat.
I saw another patient yesterday. I can just mention briefly while you're thinking if you have any other questions. But this is a patient who had breast cancer and had extensive surgery. And she is going to see plastic surgery. And they sent her to us for, she requires 40 pounds of weight loss before she can have her definitive reconstruction surgery. And so that's just another type of patient that is coming to see us that relates to cancer. And sometimes in order to really have the safest operation with the best results, they are given specific weight loss goals. And so that would be another patient to consider referring to us if you're having trouble helping your patients get to those weight loss goals.
Okay, well, if there are no other questions, thank you, Drs. Davison, Haggerty, and also Ward for the case presentation and for the discussion. I'm sorry I missed part of it. Finally got the technical issues taken care of. So I do want to, I'm going to share my screen one more time because I did want to bring up and this is the schedule of our future sessions through February. And so our next session is going to be on September the 27th, same time, 12 to 1 p.m. The topic is going to be physical activity as cancer prevention. And so if you would like to attend that, Andy's going to put the registration link in the chat. And feel free to register for those. But you can also see with our schedule, we don't have anything scheduled for November or December. That is because since we're doing the fourth Tuesday of every month, we know we're going to be getting into the holiday season. But we are going to be reaching out to people who attended the August, September, and October sessions. One of the things we'd like to do is send everyone a survey, get some feedback on the sessions that we have done to date. Also would like to get some input on, are there topics that you would like to see in the future? So you will be getting some more information from us when we are kind of take a break around the holiday season. The other thing is that it's not a requirement that you attend each session, but we do encourage you to attend as many as possible. That way, it just helps us to build off the learnings from one session to another. And as we just saw, one of the key ingredients of any ECHO session is the interactive case-based discussions. So we do encourage you to consider presenting a clinical case during one of our upcoming sessions. This will give us an opportunity to turn knowledge into practice and make the sessions as relevant to you as possible. So if you have a case that you would like to bring forward at one of our next sessions, please send us an email. Andy is going to put the email address in the chat so that you are able to do that. So before we go, just wanted to see, are there any other questions, comments, things that we could help you with at this time? And Elizabeth says, yes, cases are an essential part and helpful. And Andy has put the email address in so that you can email us directly. And keep in mind that the cases don't need to match the didactic. So. Okay, if there are no other questions or comments, I just wanted to thank you all for being with us today as we kick off this ECHO. Apologize for any of the technical difficulties that we had, or if you had some difficulties accessing the link to get into the session. And to wish you all a good day, and we hope to see you at the September 27th session. So have a good day, everyone.
Thanks, everyone.